start your presentation. Thank you.
Thank you so much. Sorry, it took a minute to get it to be where you could see it. So the title that we chose for today's talk is, what does the future hold for pediatric cardiac nursing? And so the objectives are that I'm going to summarize the IOM Future of Nursing report, describe the concept of shared governance and the benefit of shared decision-making, and explain how communication affects teamwork and patient outcomes. Like many areas of the world, the US was facing a shortage of nurses as care was becoming more complex and the public expected accessible, evidence-based, and error-free healthcare. So the Institute of Medicine in 2010 published a report called The Future of Nursing, Leading Change and Advancing Health. And the committee was charged to answer the question, what roles can nursing assume to address the increased demand for safe, high quality, and effective healthcare services? The report in their recommendations emphasized that the registered nurse needed to use the full extent of their education, training, competencies, and collaborate with other medical staff to provide that high quality care, decrease errors, and increase safety. This means allowing and empowering nursing staff to use their education to advocate and intervene for their patients. Both physicians and nurses have unique and valuable perspectives, and then when they partner together, they can improve outcomes for patients.
Anna, can I just interrupt you?
I saw you.
Yeah,
I just saw the message.
Your screen. Yeah, thank you.
I don't know why it looks full screen to me. Are you seeing the notes version? You shouldn't be, but
yes.
Yes.
Okay, let's swap that. We can do that. There you go.
Yeah, this is better, Anna. Thank you.
It was supposed to be the other way around. Thanks so much. So this means allowing and empowering nursing staff to use their education to advocate and intervene for patients, because both sides, both physicians and nurses, have those unique and valuable perspectives that can lead to improved outcome for our patients. So this report might sound great, and you'd say, well, I would love to do this in my area, but what are the challenges faced by the nursing community in India? Now, some of it we've already talked about. We talked about the quality of education in our last talk. And the last report that I could find was that only 21% of colleges had that BSc nursing education. So you're going to miss some of the great changes that they've just enacted when you're in the A&M or GNM programs. The other concern that an article in NurseZone India proposed as challenges was the exposure to medical technology, which we talked about a little bit in our last presentation, that if you're not in the hospital setting, as we're starting to use this more complex and advanced technology, they're not going to be prepared to be in those nursing settings. Professional advancement is a challenge that going to conference or accessing medical journals, as Madeline pointed out, is something that is not accessible or not permitted. But there's different organizations such as Children's Heartlink that are committed to education. We've become very adept at virtual learning over the last year and a half of the pandemic. And this is something that we can continue as we're doing today to have access to education for nurses. For example, in my unit, I teach a certification class that went virtual during the pandemic. And now that it's starting to get better, we'll probably still stay virtual because it increases accessibility and convenience for the nurses to attend. Nurses that perhaps would not come are now able to come to the class. And then we have the issue with the public perception of nursing in India, which we just spoke about. And it's almost 38% of the healthcare providers. So these are all areas of things to work on that you're very familiar with. But what can we do now? What can we do now that compensation that we don't have a lot of access to change or public perception? Shared governance is something that can start at the unit level in your hospital today. It's a professional practice model that's founded on principles of partnership, equity, accountability, and ownership. That you have this framework that lets the nurses at the bedside and throughout the care continuum enable sustainable and decisions that support a design for excellent patient care. And what you do is you encourage and empower nurses to participate in making decisions that impact their practice. If it's a way we do a dressing change, if it's a way we move patients through our unit, if it's a way we offer education to one another. And the reason this is so helpful is that research has shown that it improves the nurse's work environment, it improves satisfaction and nursing retention, but most importantly, it also improves patient outcomes. In order to implement this, you have to shift from a top-down management style where your nursing director, nursing manager, nursing leadership make all the decisions and have them go down to the nursing staff. This is a change to a collaborative model where all nurses of all levels, including those at the bedside, participate together collaboratively to make decisions for the best of the unit. More contemporary models are also interprofessional, including our medical and other professional care teams in these models. But it's important and essential to have leadership support. You have to have that top-down management say that they're dedicated and willing to do this. And then you educate the staff. What does this mean? When I first heard this, when it came to my ICU, it was a learning curve to understand that I was part of the decision-making and my view was important. We've all had policies that have changed that we did not get a decision with or did not get our view heard and realized it wasn't very practical at the bedside, that wouldn't really be successful. This model lets all those voices to be heard. And you have to have active engagement in decision-making for policies, procedures. You form councils with a reporting structure on how the information goes up and down the chain of command. And you use quality improvement frameworks to make changes. Quality improvement frameworks allow you to make small incremental changes and test them to make sure they're successful. The third recommendation in the IOM report was to be full partners in healthcare. That means shared decision-making model with both nurses and physicians collaborating as true partners and equals with different shared knowledge and expertise. It helps coordinate care. It makes situational awareness of what both nurses and physicians are concerned about with their patient due to their different lens of expertise. It distributes the workload and it creates a healthy work environment. And the result is you have improved patient outcomes, improved patient and family satisfaction, and you also have provider satisfaction. So at Boston Children's Hospital, we have many nurse-physician collaboration in different CICU projects. And these are some of the examples of policy improvement or quality improvement projects like our CPR review committee or morbidity and mortality or some of our adverse events. We also have collaborative committees that talk about the ethical challenges or end of life challenges that we face in the ICU. And quarterly, we have a parent and family advisory council where a parent who has spent a long time in our CICU comes back and shares their perspective, their things that they think worked well, or things that we have areas where we can improve. So what is the elephant in the room? What are the barriers to this collaboration and this sharing and equal status of the both physician and nurses? You might be thinking, this sounds great, but I've been a nurse a long time. I have great ideas and I want to help my peers and my patients. But what are our barriers? We work in a complex care environment with very high stakes. Our patients are some of the sickest in our hospitals, and we're using complex advanced technology. So this can lead to conflict. There's many sources of conflict in the CICU. As we mentioned, our patients are critically ill. We have multiple providers, cardiologists, ICU physicians, anesthesiologists, cardiac surgeons, and our clinician-patient ratios may not be optimal. We can have issues with communication or confidence or trust. We have ethical dilemmas. We are pushing the boundaries every day as we're learning how to care for these complex patients. So that means our approach may not be standardized. One person may not expect what the next person does because that wasn't the way they would do it. Every day we have new technology. People are looking at our outcomes. What is our infection rate? What is our mortality rate? People can have personal issues, or there can be historic triggers that cause conflict. But what are the consequences of conflict? Is this just an argument between two people and it doesn't matter and everybody gets over it in the end? Actually, what research has showed is that human factors, leadership, and communication issues are present in 60% of all sentinel events that are reported to the Joint Commission here in the United States. And sentinel events are those events that are unexpected and not related to a patient's medical condition that results in death or serious harm. So these are our most severe and most worrisome events. And during areas of conflict or consequences of conflict, these are the things that are affected. So a study that was published by Atul Gawande et al. Analyzed areas that were reported by surgeons. And you can see that a high percentage of their areas were attributed to communication, workload, and leadership. So what do we do about this? If we know that 50% of errors are due to a lack of communication in medicine, what are those affected by? And often we have these highly trained, intelligent teams. So why do we have these issues? And some of them can be tone. Someone said something in a way that offended someone else, and so then communication broke down. Or there's no standard format on how we relay our concerns. It could be someone's personal style or a hierarchical system that all of us face. Sometimes it's just hurry and distraction, and so critical elements are not relayed between two care providers. So if we think of our teams only in this hierarchical manner, with information going from a senior clinician to trainees or bedside providers, it can interrupt our teamwork because now there's no information going from the trainees or bedside caregivers who may have updated, more accurate, or more recent information. And now you have a lack of effective teamwork, and it can allow destructive behavior. The consequences are that now we have impaired communication that impairs team function and outcome. So communication across authority gradient, it does not mean that senior clinicians don't have valuable, important information to relay. We just can't have it only be from top down. We lose a lot of valuable information and we block communication. So how do we address this conflict that we all agree can happen in our ICUs? It's really by learning and practicing communication skills, learning and practicing conflict resolution skills, and personal management. How do we handle ourselves when we're frustrated, upset, or disagree with another care provider? Critical language can help. Voice your concern. Keep track of what your tone is. You can only control what you're doing, and state facts. We often use the SBAR format, and we've really gone this to sort of being the backbone of our communication. Everyone in our hospital knows if you say, I am concerned, that means that you're concerned. Stop, listen to what they have to say. And then we do it in this format, which feels a little bit awkward when you first start, but it's actually very helpful to say, this is the situation. I am concerned because this is what is going on with my patient. The background, this is what happened yesterday. This is what we decided. My assessment, I don't think this is working well. I think something else would work better, would be your recommendation. This sort of structured way in using critical language keeps emotions and offense out of our conversations, and it focuses on the facts. And it's not saying one provider is wrong or doesn't know anything. It's really just saying, I have these concerns. But does that mean you're always the one that's going to be correct? No, you can use this other mnemonic called state your path. Share your facts, non-controversial, non-insulting, and persuasive. Lead others to your conclusions through the facts, through your lens, what you've seen gone on with the patient, with the policy, with your healthcare team. Tell your story without piling it on. That means don't say, well, yesterday I said this, and last week you didn't listen to me about that. And if you had only listened to me, just tell your story with the facts, but also ask others for their facts. Perhaps there's updated information that you haven't yet heard, or when they've tried this another time, why it didn't work and they didn't feel it was effective. Talk tentatively. Tentatively doesn't mean don't share your facts and don't be clear. It means be respectful, be cautious in your manner that you're saying, this is what I think. What do you think? And really encourage that testing. Invite others' views. Do you think this is correct? Is this what you've seen with this patient? And maybe perhaps play devil's advocate. Well, if we don't do that, what will happen next? And these kind of communication strategies can really break down that barrier. If we say that more than 50% of errors are due to communication, it sort of is important to us as we do this critical care and take care of these very vulnerable patients to work on our communication so that we don't have those breakdowns and loss of information. So in summary, the pediatric cardiac care is becoming more complex and nurses need to practice to their full extent. It was very exciting to hear what we're doing to improve education for nurses in India to make them better prepared. But shared governance is a collaborative model that improves nurse work environment, satisfaction, and retention while improving patient outcomes. This is a free unit-based model that can be started tomorrow if you are interested in your unit and doesn't have to wait for government input. And shared decision-making and conflict resolution are essential to creating a collaborative and healthy ICU environment where everyone is sharing their view for the best outcome of our patients and faculty. Thank you so much.